Croup, antibiotics no help. Dexamethasone is off the Auckland guidelines. I don't know why. It's not on the pathway. So dexamethasone does help, or you can give prednisone 2 milligrams per kilograms for 3 days. So no antibiotics for Croup.
That's sort of what we've been talking about.
Yeah, so is there any point, should we talk a little bit about what it's like to have a patient come in wanting antibiotics? What do people do? If you don't think if they want antibiotics and you don't think they need them, what do people do here? How much do you go down fighting?
I make them an appointment in 1 week and I tell them to cancel it if they don't need it.
And what do you give them?
90% of the time they don't come back.
Do they have to pay again? Because that's always the issue, isn't it?
They do.
Are you? Well, what fees do you charge for a?
I'm in quite a white middle class area at the moment, and it's $40 or $45. Cheap.
Because that's a tricky bit, isn't
That's
it?
what I
People
think,
have to pay to come back, and they feel a bit irritated by that. Other strategies? Who's got an award-winning strategy?
So our clinic, they tend to go, no, you don't need your antibiotics. You know, this is why. And then they get lots of advice around nasal rinses and
give them something else.
Yeah.
drinking fluids, paracetamol, all those kinds of things. So they still walk out with their paracetamol, so they feel like they've got some value for their money.
Yeah.
But they don't have.
Well, that's why I think I had a little bit of paper in our clinic. In fact, PHARMAC are designing one modelled on our one. So it's in the computer under Common Cold, and you just print it out.
But the other thing is that I work in Meningitis, so we have quite a high malady-specific island number on our roll. So we have a lot of rheumatic fever screening and a lot of prophylactic antibiotics being stopped at day 3.
Because the throat swabs are negative, yeah.
As with everything, you have a campaign that's directed at, a reasonably small group of people within your community, and then everybody else wants to have it. And so the amount of antibiotic use as an unintended consequence among the middle class Asians and Pākehā has gone up considerably. Now, the antibiotic use hasn't gone up anywhere near as much as among Māori and Pacific, but still there's been a significant increase in throat swabbing. So we saw the numbers of throat swabs at Auckland and lab tests among middle class Pākehā and Asians went up about 5-fold. So it was nowhere near as much as among Māori and Pacific, which was where there was an expectation that there's throat swabbing, right? But that's still 5-fold throat swabs, and we know that among kids, school kids, 15 to 20% will be positive, whether it's relevant or not, and then 15 to 20% of those are almost certainly going to get a Moxil, because as I said before, you give a doctor or a nurse a positive culture, you've got all this education and advertising going on. Who's not going to treat under those circumstances? So I suspect that there's actually harm that's taking place as an unintended consequence of this program that no one has wanted to talk about because it's a bit uncomfortable.
Is it going to be possible to stop it if it's not working? I mean, that's going to be the...
Well, I think... Oh, you mean the whole program? Yeah,
I mean, let's say we decide it's not working, who's going to be brave enough to pull the plug on it?
That's right. It's a bit of a juggernaut, really. But also, we don't have, without a good alternative. And the vaccine is so complicated because the rheumatic fever is thought to be a mimicry, a sort of an immunological mimicry of. So it makes the vaccine very. So it's all. So I think it's a very, very difficult issue. But in terms of antibiotic stewardship, I don't think this program has overall been beneficial to antibiotic stewardship in our community.
Because I'm in Hawke's Bay, so part of that program. But when you get a result of very scanty,
Yeah.
we have to treat.
Yes, I think it's very difficult.
It's about the quality of when you take the swab, and I know it's about the disease process, but
yeah, I think it's really difficult. So we know that that group A strep colonises the back of our throat. Yeah. So, but the thing is, the science is so bad for this whole area, because when we say how colonisation was defined was just where they had people that had sore throats and were group A positive in the culture, and then they also did serology testing. And then if the serology testing was negative, they said, oh, that was colonisation. But that's not actually perfectly scientifically valid, because that could be causing a local infection and not necessarily cause a serological response. And then when GPs are asking for all these strep tests and we're turning them down, because we are turning a lot of them down, we're saying, well, it's a useless test. That's part of the reason why we're turning them down. So then we define whether something's colonisation or genuine infection on the basis of what we say in another breath is a useless test. So but Dinny used to always say that it didn't matter how much strep was, whether it was a light growth or a heavy growth, that it was a presence that was relevant. And I think there was a study that was based on, I can't remember, but that probably is fair enough, because as you say, what part of the illness are you measuring it in? How well was the swab collected? Did it lie in the car for a while? Was it a hot day in Auckland? Do you know what I mean? So there's lots and lots of different variables, and so I think it's a situation where you can't really quantify it and say that the quantification helps with an interpretation clinically.
Well, it even gets worse, because I think there was a PhD from Melbourne, albeit done in Melbourne, where they did blood tests compared to the throat, and actually the symptoms and signs just didn't correlate with the blood tests at all. So it's like all these things, there's symptom clusters that we have to try and make sense of, and that is particularly...
Yes.
And we haven't quite got our head around that these aren't diagnoses, these are symptom clusters.
And that was another one of the reasons why I was concerned about the way the program was set up, because it's very focused on sore throats as the entry into the program. Like you have a sore throat, you get a throat swab and your penicillin and your amoxicillin. Where the few studies that there's two facts, that when they have kids with acute rheumatic fever and they ask them about recent sore throats, up to 60% don't remember a recent sore throat. And then there's another study, and it's one small study, but that children with rheumatic fever, it appeared that they were more likely to get rheumatic fever if it was the same strain reinfecting over and over again, which makes sense immunologically, because you're building up that immunological response. But there's also some evidence that if you're infected over and over and over again with the same strain, you develop some degree of immunity such that you don't get symptoms. So it may well be that the children who are at the greatest risk are the ones that are getting repeat infections with the same strain, and they're not getting symptoms with those subsequent infections, and it may be those subsequent infections that they're not symptomatic with are the ones that are really going to go on to cause. So when I just think it's a very, very complex, and we've done what we can. Our response has been what we can with the tools that we've got, but that's such a complicated area that I don't know.
Well, can I just give my view? I think we should almost give up in primary care doing it and rely on the school program. Okay, because the reason with the school program is it's systematic and all kids are exposed. By the time 100 kids out there get a sore throat, by the time they get in to see us, and particularly if they're high-risk kids, they may have trouble with transport. By the time they get into us, that's just a tip of an iceberg. The only way to get the iceberg, I think, or get the ice, is through the school program. And if anything's going to work, it's going to be the school program. Why they try to move into primary care, I thought that probably was a bit dumb. I mean, there is the problem, obviously, in the school holidays. It's not going on. That's a bit of a problem.
At least it's summer.
But and this whole problem of some kids not getting the symptoms.
That's why I thought everyone should just get a jab.
Everyone get a jab? Okay.
Might be not related, but I'm just thinking about the rates for mighty children with glomerulonephritis.
Yes.
What's that like at the moment?
I don't think we keep data on that. I don't think that's a notifiable disease. So we only know rheumatic fever rates because it's a notifiable disease, and I don't think that post-strep GN is. So I don't really know. That would actually be very interesting to know if those rates have dropped off. That would be a nice project actually for someone who wanted a project, because you could look at the rheumatic fever rates and then you could look at ICD-10 10 discharge codes, because most kids with GN would go into hospital, wouldn't they? Yeah. So that would be a really interesting project, actually, to see if rates had dropped off with the introduction of the program.
Well, I've heard from school teachers they really like the school program because some of these kids often had skin infections, and the teams that were coming around were so the school teachers didn't have to take responsibility for these kids. They're often taking these kids off to the doctor, and actually the kids were then getting treatment in schools, because there's not a consistent nursing service in primary schools. There's one nurse to 3 schools, I think, and the teachers were ending up having to do a lot of the healthcare. Whereas in the high schools they have the nurses based there.
But that, of course, is the final thing. I'd forgotten about this. The final thing that Dinny had a few disagreements with some of her colleagues about is some people believe that skin infections are really important for rheumatic fever, and so we're just with our program focusing so much on throat, although I know that the schools now in South Auckland are focusing on skin as well. But we could be missing a whole chunk of what's causing the rheumatic fever with it, because we haven't been focusing so much on skin as well. But that is, again, controversial and disputed. I know it's not a perfect solution. All the children at risk.
That would be a lot.
I know.
Well, the other thing is just being totally onto the ones who've had the first episode of rheumatic fever. But how much damage is done in the first episode?
Well, that's the thing. But the first episode, I think, can be quite asymptomatic or minimally symptomatic. The alternative, I think, would be also skip the throat swabs and give all the children penicillin intermittently. Because the throat swabbing is missing the asymptomatic kids that may be dry. And you see, there was a big scraps about whether, because we're treating carriage, we know we're treating carriage. And the Americans say carriage doesn't lead to rheumatic fever. And Dinny thought carriage did lead to rheumatic fever. And also there was this thing, well, if we treat carriage, we lower the burden of strep in society. But I don't think there's any evidence of that in a big city like Auckland. There was some stuff from Indian reservations in the 1950s, but that's a whole different kettle of fish. So we just need a vaccine.
And you thought pharyngitis was easy, eh?
I know.
And the other thing is that they did a survey in Northland, I think, and they found that there was 50% more heart disease than they expected. So a lot of these cases were asymptomatic.
And so that's the other thing. And I think when Nigel Wilson and Rachel Webb went to the Pacific Islands and did scans on kids, they found more rheumatic heart disease than they. We could talk about rheumatic fever all day, but we should talk about genitalia infections.
Yeah, okay. So what we might do is get some priorities and just get you to think of something we haven't covered that you would like to know about, and we'll be a bit more directive. Just the respiratory thing, I think, needed that time because it is the diagnoses are difficult. They're symptom clusters rather than diagnoses. You often don't have microbiology. The microbiology is not helpful, which is really good to having your view.